Hi, everybody. This is our second webinar. My name is Dr. Corey Hunter. I'm the Executive Director of the Ainsworth Institute of Pain Management, and I'm an Assistant Clinical Professor of Physical Medicine Rehabilitation at Mount Sinai Hospital. And I'm going to do another webinar, so there's still some questions I think that people had that I didn't address. So I wanted to do a second one to kind of really cover a few more things that people wanted to flush out, some things that people know, and really just in addition to covering what's relevant to my specialty with pain management. I really realized how much disinformation there is out there on COVID-19. So as a doctor, I wanted to try to put some more information out there, some correct information, and I guess kind of combat some of the disinformation that's there. So a little bit about me. So I've been board certified in pain management for about 10 years now. I did my training at NYU and Cornell, and in 2011, I founded the Ainsworth Institute of Pain Management. So the predominant part of my life I've spent doing research, bench research, clinical trials, a lot of research on stem cells, and more recently been doing some, the bulk of my work has been on medical devices for pain. But I can tell you I've never really seen anything like this, anything that we're going through now. I've never seen anything like this. When I was in medical school, I remember, a lot of the doctors that were training us were always talking about that, one day that there's going to be an epidemic. But I think what people were talking about was bacteria. This being a virus, I don't think it was anything that anybody had really ever contemplated. There's nothing anybody's ever seen or really predicted was going to happen, I guess, to this level. So I'm going to hopefully try to, cover as much as I can. At the end, I'll leave it open for questions if anybody has any questions or things that they feel like weren't addressed during this. So this is the world that we're in as of today. We're looking at cluster maps. The words flatten the curve and social distancing have really become as commonplace as the Kardashians. So we're really becoming, I guess, comfortable, for better or for worse, with what's going on. Unfortunately, people are still kind of resisting the concept of social distancing. Being a doctor in New York City, one of the densest cities in the United States, and also, unfortunately, the absolute epicenter of the outbreak in the United States, and we have more cases in the world. So people are still going outside. People are still traveling in groups. Just going outside a little while ago, the sun finally came out for the first time in a couple of days, and people are back outside as if the virus cares what the weather's like. So people need to get used to this. I think the longer that we resist it, the longer that this is going to last. So really, really briefly, I don't know how much people know about the virus. A lot of the news outlets, I think, seem to be more interested in kind of pushing their political platform than really keeping people informed. I think news sometimes cares more about ratings than they do about keeping people calm. So this is just a little bit about it, very, very brief, very cursory. People want to know why we can't just use antibiotics on it, or people are confused because some of the stuff that's going around with azithromycin, and I'm going to go into that. Why can't we just use antibiotics? Viruses don't work with antibiotics. Bacteria do. Viruses, your body has to run its course, or you have to have a vaccine, which is something that still is months away. So that's why. Now, coronavirus itself isn't new. This has been around. So if you pick up a bottle of like Lysol or Clorox wipes and you look on it, you're actually going to see coronavirus on there. That's not because they quickly got that printed on the labels in the last month or two. Coronavirus has been around for a long time. This is a new strain, which is why you hear people calling it a novel strain. So this is brand new. It mutated somehow. We don't know yet. It attacks the upper respiratory system predominantly, and then it leads to pneumonia or shortness of breath. What pneumonia is basically a consolidation of the lungs, where the lungs will fill up with fluid. The lungs are supposed to be all air, so the less room there is for air, the less oxygen you can exchange, and then people become short of breath. It's extremely contagious. This is something that's it's elegant how contagious it is. People can carry it for 2 weeks and not even know it. People can have the virus completely and not even know it. So we're finding out now that people are having it, it's going completely undetected, and they're transmitting it to people thinking, well, I feel fine. I don't have a fever. I don't even have a sore throat or a cough. So I must be fine. And people are going out and they're infecting other people. And whether people want to believe it or not, this is more dangerous than the flu. There are some people that are I guess conspiracy theorists that are talking about how this is no more dangerous than that, or they're bringing up statistics from H1N1. This is killing people very quickly. The elderly, the people who are immunocompromised, people that have even the slightest flaw in their genetics, this virus is taking full advantage of them. And so this is something that I came across. Someone actually gave to me. So we found out now that there's actually 8 different strains of this. So the SARS-CoV-2, which is the virus, the COVID-19 virus, they found out that there's not 8 different strains, and it seems to be these strains are more or less isolated to the different continents or the different geographical areas that they're at. And so this is giving people, the scientists that are studying it, a little bit more information about it, and it's going to get them closer to a vaccine, understanding how this thing mutates and how it tracks. So this is actually something very interesting that came across. If you Google that term right there, I took it directly from the article. You can read more in depth about it. So it is mutating, but the scientists actually think this is a good sign. This is something that I came across in Time Out New York yesterday. It was unnerving. I live in the bottom part of Manhattan there in the 308, 309, and 310, general region. And you can see, that there's not a single neighborhood that's not affected. That white area in the bottom right of Queens, that's JFK. And in the top part up there, next to 402, that's LaGuardia. So that's not that it's not infected, but you can see these areas. The bottom right is the legend, but every single part of New York City is affected. Unfortunately, Queens and Brooklyn seem to be the most infected. Elmhurst Hospital, which is in Queens, is pretty much the epicenter of the country right now, where they're experiencing double-digit deaths a day. They're experiencing at least 20 deaths a day now. So my heart goes out to the health practitioners that are there. God bless you. You're really, you guys are real superheroes for what you're doing. Every doctor is at every hospital right now, but you can see if you're in one of those areas right now, you should be staying inside. This hasn't spared any part of New York City. One thing that people are asking, pretty much almost every patient I see that we're visiting, doing with telemedicine, they're asking, should I just pick up and leave? And the answer is no. So I'm originally from Florida. I was born and raised in Miami. And one thing, growing up in Miami that we know is that it's where snowbirds come. So it's where people from New York come to retire. Everybody from New York seems to have a home there, or they have family there. So the vast majority of people from New York, with this going on, they seem to feel safer just picking up and leaving. The problem is that now you're taking the virus with you, and some of these people don't think that they have it, and it's making it harder for epidemiologists to track this. And now Florida, which has the largest concentration of elderly in the country, which is where people go to retire, this thing is going to run through there like a wolf in a hen house, because now people are taking it from New York, and they're taking it with themselves down there. So the best advice I can tell you is do what we're doing. Stick it out in New York. If you're from New York and you're here, stick it out here. If you have family out in the suburbs, that's fine. But I can tell you, being here in New York, the supermarkets are basically empty. They're fully stocked with food, and the city is empty. So if you're still here and you haven't left yet, don't leave. Just stick it out here and don't take the virus with you. If you do, don't take for granted that you don't have the symptoms with you. Wherever it is that you go, quarantine yourself. If you're leaving New York, quarantine yourself for 14 days. This was actually recommended by the federal government. So again, the answer to that is no. Stay put and stay inside. I've gotten this message from a bunch of people from the last webinar that we did last week, asking, I think I have COVID-19. What do I do if I think I have the symptoms? So this is just kind of a quick steps to take. The first thing everybody wants to ask is I think I have it. Where can I go to get tested? The testing is painful. So the testing is if you look it up, it's about a 6-inch Q-tip swab that they shove through your nose all the way to the very back of your throat. It just doesn't go slightly up your nose. It goes to the back of your nose, and it will induce a gag reflex. So unless you really, really, really think you need to get tested, don't. The testing takes 5 days. So Abbott just approved, or just got a testing approved by the FDA that takes about 5 minutes, but it's not readily available yet. So the one that's still there is the one that's a little bit invasive. You have to stick a swab to the back of your throat, and it takes 5 days. So what you're going to do in those 5 days is you're going to stay inside and avoid contact with others. So you could do that anyway. So if you think you have it, stay inside. Just assume you have it until proven otherwise. If your symptoms get worse, then yes, at that point you should probably get tested, and then you can get treatment. Avoid emergency rooms. This one people are surprised to hear. Reason being is that if you don't have it, you're virtually guaranteeing that you will get it. Emergency rooms are packed with people that do have it. So if you're going there, if you don't have it, you're going to get it. If you're short of breath, if you have family members that are short of breath, you can't call an ambulance on their behalf. They have to call 911 themselves and have to have someone come and get them. If you really are convinced you have it, you're short of breath and you really can't breathe and you're having trouble taking a breath, don't take a cab. Don't take an Uber or a Via. Just call 911, have them come pick you up. Take your temperature. If you have a fever and you're short of breath, chances are you probably do have it. Some people are saying like, oh, I have a sore throat, I have a cough, but they have no fever. The hallmark sign of this is a fever. So if you have a sustained fever for a couple days, chances are you have it. And again, most importantly, please just wash your hands. So one of the things that's out there is people are going on the internet and they're hearing, I heard there's a treatment for it. And the one that's making the rounds is the hydroxychloroquine, azithromycin, and zinc. So is it real or is it a hoax? We don't know yet. I would say every doctor is hopeful that it will work. Hydroxychloroquine or Plaquenil is an old drug. We use it for malaria. And for whatever reason, the people that are using it seem to think that it's like hones in on the virus and it somehow protects cells. So the way malaria works is it's like a microscopic parasite and it gets inside cells. So the Plaquenil seems to do something to protect the cells from the virus, is what people think it does. Azithromycin is an antibiotic, so it doesn't work on viruses. But what we think it does is it somehow protects the lungs from getting ill, from developing like a pneumonia along with it. We don't know. There's a lot of evidence to show it works. There was a clinical trial that just came out. Well, not really a clinical trial, but a study where a doctor showed that it didn't work. It was no better than placebo. But I think what some people believe is for it to work, it has to be given very early on and before the person becomes like fully symptomatic, where you believe that the person has it, you give it to them early on. But once it's like full-fledged, like on there, and the person is, intubated, that's I think past the point where it's not going to work. So we're not advising people should take it preemptively or prophylactically yet, but the study's still going, and we're all very, very hopeful for it. This is really important as far as like the scams and the hoaxes. Just when I think people can't stoop any lower in medicine and not take advantage of people, I'm surprised because people find a way to do it. When I originally made this slide last week, there was one company that was out there that I was very surprised at because it's a very legitimate company, and they were touting exosomes as a potential cure for COVID-19. Now, that's not true. Exosomes haven't even been proven for the things that it was used for before COVID-19. It didn't even have proof before COVID-19 existed. It's predominantly something that's used in regenerative medicine for people, if you've heard of PRP or platelet-rich plasma or stem cell therapy for, like chronic pain. Exosomes was like the brand new thing. And it was still in studies for that. It's a cash procedure, but one of the companies that has exosomes was putting out there, and there was more, fine print than like a Carly's commercial, but they're putting it out there. So, I reported them and it got taken down. One of my best friends out in California, he does a lot of regenerative medicine and stem cell therapy like me, and he forwarded me another email about something very similar for stem cell therapy, and they wanted to set up a call with him for the doctor that's using stem cells. He has a treatment protocol for COVID-19. Now, we know better, but there are some doctors out there that aren't as up on the literature, and they might believe it. There are patients out there that don't know the difference, and if they come across these things, they'll believe it. So I'm telling you now, so you can hear it, these things don't exist. So exosomes do not work to treat COVID-19. Stem cell therapy does not work to treat COVID-19. Immune system boosters, these are things that are really controversial as is, has not been proven to treat COVID-19. Holistic treatments, there is not a holistic treatment on the planet right now that has been proven with any level 1 evidence to treat COVID-19. There is no cure and there is no vaccine. Some people are talking about with conspiracy theories that there was the government had a vaccine for the coronavirus back in 2019 and they're holding off on it. That's not true. This was something that a couple companies were researching for the original coronavirus. Now, this is a novel strain and it mutated, so it won't work on that. But they were working on vaccines for it, but the money dried up, so they abandoned it. But before any company even goes forward with the research, they always file for a patent because they want to have a patent before it comes out. They don't want someone else to compete with them and take their idea. So there's always a patent out there for drugs that don't exist. So if you see that circling and making itself viral on social media, it's not true. There is no vaccine yet. So if you think you have it, don't search for a cure on the internet. Don't fall victim to people that are preying on you. Call your primary care doctor and follow the evidence. So, what now? So my patients, one of the things they've been kind of saying in all their emails to me, which is what prompted me to do this webinar to begin with, is, the world is on pause, but my pain is still going. What am I supposed to do now? So that's really what kind of prompted this. So this is what I'm going to spend the rest of the time on, is kind of going over, the people that are in pain, what they should do and how they're supposed to get through this, because pain doesn't wait and pain doesn't take a day off. That's why I kept my practice open. So I can be there for my patients. My patients' pain is not going to, take a pause just because this virus is out there, and I told people that they have to stay at home. So the impact on medicine, as you imagine, that there is going to be a very palpable impact on it, but it's not what you think. One of the first things I think that all pain patients encountered was the word elective medicine. And the reason why elective medicine, why people are talking about that is every hospital since the 1950s, ever since like the nuclear, nuclear standoff between the Soviet Union and the United States, people feared a nuclear holocaust. And if that happened, all hospitals were basically given an emergency protocol that on a week's notice, you can take any operating room and you can convert the pressure from an operating room and convert each operating room into an ICU bed. The reason that works is an operating room works on negative pressure, so it sucks everything out and it keeps the room sterile. An ICU bed works on positive pressure. That room is to keep everything in. In every ICU bed or ICU room, you'll have a ventilator to keep the person breathing if they suddenly fall short of breath and they can't breathe on their own. Every operating room has an anesthesia machine, which is meant to work as a temporary ventilator to help the person breathe during surgery. So all elective medicine, so anything that is not considered emergent, was moved out of a hospital to basically make room to keep only the emergency medicine there, for just to keep those rooms as operating rooms. And then the rest of the rooms that would be used for elective medicine are now being converted into ICU beds. And that finished happening about a week or two ago. So across the entire United States, there's less than about 90,000 ICU beds, including every hospital in the country. But there's probably close to 600,000 or 700,000 operating rooms. So now I wouldn't say that many, probably more like, I think 300,000 is probably a more accurate number. So instantly, the United States probably tripled its ICU capacity. Now, make no mistake, that's still not enough. It's still not enough to make room if the United States doesn't, flatten the curve and if it doesn't slow this down. So those beds won't mean nearly enough, but it's going to help. So that's where the word elective medicine came from, because they're trying to figure out which ones they should move forward with and which ones not to. And unfortunately, pain by a lot of people has been deemed, quote unquote, elective. Now, again, it's also to conserve supplies, it's to free up doctors so they can use people at hospitals that have been called in. It's to reduce hospital volume, it's to keep the healthy people away from the COVID-19 infected people. And it's also to keep doctors away from people that may potentially be sick. So you don't want to, even if you're not in the emergency room, if you have someone with COVID-19 that thinks that they have it, but they don't know that they have it yet, walking through the lobby of a hospital, think of all the people that are there that may be getting chemotherapy, or they're about to deliver, or a baby that was just born 2 days ago that's going to be walking within a foot of them. So you want to try to keep people away from that. And it's just most importantly, you want to keep the sick from infecting healthcare professionals, because, right now we got a job to do. So, people want to know, well, what difference am I? I'm in agony, doctor. So how can you tell me that my medicine or my condition is elective? So I don't think pain for the most part is elective. I think that, patients that are in pain, I think that it needs to be dealt with, but that doesn't go across the board. There are people that are certainly elective. So This is kind of a quick, dirty breakdown of the difference between elective and emergent. So elective is something like a cosmetic procedure. That's something that can certainly wait. A person isn't going to die if they don't get a nose job or a tummy tuck. LASIK eye surgery, you can continue wearing glasses. Varicose vein treatments, again, it's not going to kill you if you don't get it. A knee replacement, my brother had a knee replacement. He put it off for years before he got it done. So these are things you can put off. Emergency surgery, heart surgery for like a bypass if you're having a heart attack, that can't wait. A kidney transplant, childbirth, chemotherapy, those are things that can't wait. So where does pain fall in that? So if a person is getting, basic steroid shots in their joint for arthritis, I'm pretty sure that most of the people out there, if they got a bum knee, they probably think to themselves, yeah, it stinks having it, but I could probably put it off for a couple weeks. So I think like probably the rule of thumb is if you can think to yourself, like, I could live with this for another couple weeks, that's probably elective. And if you're managing with over-the-counter medications, again, let's wait this out. Let's revisit this in about a month when things died down. Emergency is someone who is in a pain crisis, someone who is actively thinking to themselves, like, if I have to deal with this even for another hour, I'm going to go to an emergency room. That's what we call a pain crisis. So uncontrolled pain that would otherwise, someone saying to themselves, like, I can't make it through the next day unless you give me like oxycodone. That's emergent. Someone who has an intrathecal pump, I have a number of them in my practice. I couldn't even imagine shutting down my practice because what would these patients do? This needs to be filled and managed in person. These people need more medication. They need less medication to refill it. That is an in-person visit, so I can't close down. If someone has a spinal cord stimulator or some kind of surgery and the device isn't working properly or there's an infection, that is emergent. So these are things where patients need to come in, they need to see me, and I need to make myself available for them. And this is a quote from one of my patients, but I think that this would probably apply to anybody. What am I supposed to do? I just can't wait in pain for the next 2 months. And you're right. And that's what this is here for, is to kind of go through some options that we have for you. So this was pretty much the first slide that I came up with. And I think this is something that people still don't know the difference about. So about a month ago, some of the doctors in France had believed that ibuprofen was making the bug worse. So anti-inflammatories create an enzyme, and they believed that the COVID-19 virus was feeding off of that enzyme, and it was making it worse. And then WHO, about a week later, that's the World Health Organization, they piggybacked on that, and they said, you know what? We agree with these doctors in France. We're saying that people should not take ibuprofen if they think they have COVID-19, or they should just avoid it altogether right now. The reason why it's relevant is because it's an antipyretic, which means it's a fever reducer. So as I was mentioning, one of the first things that COVID-19 gives people is a sustained fever for several days, and your first instinct is to take Tylenol, ibuprofen. Some people prefer ibuprofen because they think it's stronger. So patients in pain, this is one of the go-to drugs, Advil, ibuprofen. So what do? So the WHO actually retracted it. It's fine. It's safe. The United States, the FDA actually backtracked on it. They said there wasn't enough evidence to support that. So for anybody who's in pain, ibuprofen is safe to take. Opioids. Anybody who knows me in my practice knows that I'm particularly passionate about opioids, about people not taking opioids. My mother was a prescription drug addict. In the 80s, she suffered from chronic migraine headaches. Back then, the go-to, people really didn't know the dangers of medications, of addictive medications. So the drug of choice back then in the 80s was Firanol and Fioricet with codeine. So, I remember her going through like 100 pills in a day. So I'm very outspoken against people taking opioids. I'm proudly, year after year, on the bottom 3% of prescribers nationally, and I like to keep it that way. So I don't want you to think that I'm just coming at this topic biased. There is actually evidence to support my decision on this. So people have asked, and countless patients have asked me on emails, look, doc, I can't come in. Can you just prescribe me some Percocet to get me through this and I'll be fine? The answer is no. The reason being is not just forget everything I said about opioids being addictive, or everything that happens with it. Now, it only takes 3 days for a person to develop an addiction to an opioid. This has nothing to do with addiction. Opioids, and this has been shown for over 20 years worth of evidence, there's a direct negative correlation between your immune system and the amount of opioids you're on. So that means the more opioids you take, the less your immune system works. Now, right now, a lot of people are getting the virus and they're fighting it and they're surviving it. That's because their immune systems are doing their job. A lot of people are getting the virus and they're fighting it off completely and they're not showing any symptoms at all. That's because their immune system is fighting it off. You need to give yourself and your immune system the best chance you can to fight this evil virus. And the way that happens is to stay off opioids. So we're all agreeing amongst the doctors is we're not starting anybody on any new opioid prescriptions, and anybody who's on them, we're not increasing them. So if you're at a point where you feel like you cannot get through your pain unless we start a prescription for you, I need to see you, and we need to do something in person. If your pain is so bad that you're like, Doc, you have to increase my opioids, you got to come in because there's something we got to do. We have to do anything possible to avoid you taking opioids. Supplements, any remedies or anything out there that can help help my chances with this. So, for those that are out there, they're the holistic doctors or the ones that are, the anti-vaxxers that, give us all the joke ammunition in the world about essential oils and things like that. There really isn't anything that I would recommend except for zinc. So zinc has been shown to actually really boost the immune system. My best friend growing up in Miami, he swore by zinc and, stress tabs and vitamin C. And, it's funny, some 30 years later, after that being like his home remedy, I'm actually putting this here in a webinar. So zinc has been shown to be effective against the COVID-19 virus and is part of the cocktail with the Plaquenil, Z-Pak, and zinc. So taken together, they're supposed to be effective, but by no means, if you take this as a substitute for social distancing or conventional medical care, you still need to abide by everything that people are doing. I think that the only the information you can glean from this is it would help your chances of fighting it off, and it may help your chances of, maybe not getting it. Potentially, some people are saying, I don't know that that's really valid, but there's no harm in taking it within the recommended daily allowances. But again, just follow the guidance of your healthcare professionals and stay inside. So the most important one of all this is the one that I heard countless times from new patients. My doctor closed up, what do I do now? So your doctor's closing for a very good reason, because he or she is doing what he's supposed to do. If they have a practice where they don't have to stay open, they're supposed to close. I can't close because I have patients that are depending on me. It's not that your doctor can't depend on you, but I have patients that have medical devices and I have patients with pumps, so I have to stay open. So the ones that don't have some of those obligations, they're allowed to close, and they're doing the right thing. If your doctor works at a medical center or an academic center, they were forced to close because the administration told them that their pain is considered to be a non-essential specialty, and they want that doctor to be freed up because they're probably anesthesiologists and they need to be on standby to intubate patients if they fall short of breath and they need to go on a ventilator. So they're doing the right thing. But for me, we're staying open. But again, if at all possible, if you're not a pain crisis, if your pain is something that you think you can get through with over-the-counter medication, stay home if at all possible. But if you can't, we're here. There's several of my colleagues around the country, probably one or two in each major city. We're staying open. So here at the Ainsworth Institute, we are available for select patients. So if you're seeing this and you're not one of our patients, we are open. We can help you in the interim until your doctor reopens, or if your pain clinic at your university hospital reopens. I know I trained at Cornell, and I know they closed very early on because they wanted to free up the supplies and free up the clinic and just make sure that the healthy patients weren't being mixed with the sick. They will be reopening. Your doctor isn't abandoning you. But in the meantime, if you need to see someone, we are here. One of the things that we're doing is we're offering telemedicine. So this was something that the government got right really quickly. Telemedicine was approved, in general for about a year or two ago. But the problem was it wasn't reimbursed by any insurance company. So this was considered like a concierge service. You had to pay for it. So while it was approved as a valid way to conduct and perform an encounter with a patient, no one paid for it. So this is why your doctor wasn't doing it. So now with what's going on, these telemedicine platforms and telemedicine exists, so they're offering it. And rightfully so, Medicare about 3 weeks ago, they immediately said, we're covering it. And then one after another, all the insurance companies ended up doing the right thing, and they fell one after another, and they all covered it to the point now where even workers' comp in New York, if you can believe that or not, is covering it and no fault. So everyone is covering it, from Medicaid and Obamacare to a Cadillac PPO plan and Blue Cross and Blue Shield. Everyone's covering it. We're using a pretty slick platform called Doxy, which we're sending text messages to patients, and they basically just click on the text, and it takes them right to a platform they can do right from their phone or their computer, and they sit in a virtual waiting room, and we see them. So we're doing all of our follow-up visits for patients, and now we're even doing virtual consults for brand new patients. So if you're a patient, you're watching this, and you're not a patient of ours, and you think you would like our help, we can see you without you leaving your home. We can send a prescription for an anti-inflammatory or something you may need electronically. You can send it to a pharmacy that delivers. So from beginning to end, you may not even have to leave your couch. So telemedicine has really kind of made it available, or made it possible for us to treat our patients and get them through this and keep them safe. For the patients that are emergent, for the patients that need an injection, they need a therapy, they need some kind of a treatment to get them through this because medication just isn't enough and they don't want to start an opioid, we have our own private facility where we do our procedures. So even if the hospitals and the surgery centers were open, you wouldn't want to go there because there are patients with COVID-19 that are probably walking right near you. So the facilities are sterile. But in order to get to those facilities, you're going to be walking past a lot of people with COVID-19. So that's why they're closed. But even if they were open, you wouldn't want to. We have a private facility. It's sterile. As far as we know, we have not had a single patient test positive for COVID-19 and be within our office within 2 weeks. So we're a completely sterile facility. So for the patients that do require procedures, we're able to offer them safely and privately so that they're basically the risk is as low as it could possibly get. Now, let me go here. I think I missed a slide. Here we go. Oh, I'm sorry. Okay, ketamine infusion. So this is something that we do for a lot of patients with pain, intravenous infusion therapy. So that's been around for a while. We're actually able to. I think we're the only one. One of the only ones in the country where we are actually able to get it covered by insurance. Ketamine is an old drug. It's been around since the 1960s. It was a very popular drug during the Vietnam War that allowed field medics to do surgery right in the field of battle. Surgery, conventionally has to be done in a hospital for very specific reasons that the person needs to protect their airway. The beauty of ketamine is that it can be performed like right out in the field of battle because it doesn't cause airway depression. So the person's airway stays completely intact and they can perform surgery right there without having to worry about the person stopping breathing. Then in the 1980s, some kids figured out that if you put it in a microwave and you snort it, you can take some glow sticks and go to a rave and have a good time. And then doctors and hospitals basically got rid of ketamine and they sent it to veterinary hospitals to use, and it became known as like a horse tranquilizer. It was always meant for humans. Then in the late 1990s, a doctor at my medical school at Hahnemann, by the name of Dr. Schwartzman, figured out that if you use it for pain at sub-anesthetic doses, it's a very powerful medication, can help people with all sorts of chronic pain. So for I'd say about the last 10 years since we've been open, we've been using it for a variety of types of pain very effectively, facial pain, headaches, pelvic pain, fibromyalgia, and CRPS. And I think it's an especially effective medication right now because it's not an opioid. It does act on the opioid receptor slightly, but unto itself, it's not an opioid, and it's not a steroid. Now, steroids are a little bit controversial right now in pain management because we're not quite sure if they are going to suppress the immune system, if it's going to do anything to the white blood cells that would keep someone from being able to fight the COVID-19 infection. God forbid that they get it. So those of us that are using steroids are using much lower doses and less potent versions of it. But the advantage of ketamine is it's not a steroid. So for patients that want something as non-invasive as it gets, it's basically an IV, and we give them the medication. It's very effective. We use this year-round, but it's something that we especially are promoting for patients right now, just given the advantages of it. And we use it for depression. So this is something that's been around, I'd say, for about 4 or 5 years. I know it's something that people are dealing with even more so now with everything going on with COVID because let's face it, this is a really maddening experience. So this is something, but ketamine for depression, however, is not covered by insurance. So this is something that's a bit of a cash procedure, but it's not terribly expensive. It's about 4 visits. So it's something that we are offering for patients. So if you're watching this and it's not so much pain, but you're dealing with depression and anxiety from everything that's going on, ketamine is very effective for that as well. So what do I do next? So if you have a fever or coughing, stay home. We'll do a telemedicine visit for you. 65 years of age or older, stay home. We'll do a telemedicine visit for you. Recent traveling or contact with anybody that's infected, I hope it goes without saying, stay home. Not just for us, not just for a doctor's visit or anything. Stay home. Order your food from Whole Foods on Amazon Prime. Watch Netflix. Do whatever you got to do to get through this, but don't go outside. If you need us, we can schedule a telemedicine visit for you. Just call us. We'll deal with the insurance. And like I said, all insurance companies are covering telemedicine right now across the board. There is not an insurance company that's denying it. So we can do your entire consult virtually. And for those of you that meet one of those criteria above, a fever or 65 years of age or older, someone that we wouldn't want to come outside, we'll do everything we can to offer you a therapy or treatment that wouldn't require you to come in. And if your condition can't wait, still, let's do the initial consult over telemedicine. I don't want anybody coming in that doesn't have to. There's really, short of the physical exam is really the only thing that I can't do with you being over telemedicine. I can see your face. I can, we can meet. I can really get a good idea of what's going on, review your medical history. And I think that, I can probably come up with a pretty good plan for what to do. And then if I do really feel that you need to come in, we can finish. If I can't narrow it down between 2 or 3 things and really the only thing that I need to do is do a physical exam, at that point we could get you to come in, but we can plan for a procedure and then say, it's going to be one of these 3 things based on your exam when you come in. We'll figure it out right then and there. But if it's something, can't wait, that we can do with a prescription, we'll send an electronic prescription. You don't have to come in and pick up a paper one, and we can treat this and you can stay home. But again, depending on the severity of it, if you're really in pain, and it's on a case-by-case basis, based on severity and priority, and most of all your safety, if it is something that we deem to be safe, not just for you but for us, we'll have you come in and we'll schedule a treatment. This is who we are, Ainsworth Institute of Pain Management. We're located on 57th Avenue between Park and Lex. Our phone number is 212-203-2813. Our email is info@ainpain.com. If you go to our website, www.ainsworthinstitute.com, there'll be a little link there to chat with someone live. Our office hours are generally between 9 to 4:30 or 5. So if you click on that link during the day, someone from my front desk will see your question. You can just chat with us over the computer. If you chat after hours, it'll give you a message that we'll get back to you. So I'm going to open it up for questions. If anybody wants to send sends any questions through on the text on the right-hand side of your screen. But I just want to leave everybody with one parting message. Stay safe, stay healthy, and most of all, stay home. If anybody has any questions, feel free to write them in on the right-hand side in the comment section. If not, please just feel free to send us any messages over email. Again, our email is info@ainpain.com. You can send an email to me. It's chunter@ainpain.com. So if you're seeing this after the fact, feel free to send me a message. I'm more than happy to reply. If it's, some people send me questions just about, I think I have COVID. What do I do? Some people are asking, I'd like to be a patient. My doctor is going to be closed for the next couple of weeks until May, and I can't wait. So we'll see. So Ryan, you sent a question, can ventilators really support 2 patients? I know the article you're talking about. So I saw that that was 2 doctors at Columbia that worked on it. So the chief medical officer over there basically commissioned the doctors, I think about 2 weeks ago, to figure it out. They can. That's really an emergency protocol. So the way a ventilator works is it has a splitter on it. So I think that what they did was they figured out a way to split the settings on it. So it's able to get sufficient amount of oxygen, but I think the one thing that they haven't quite worked out is if one person's infected and maybe the other one isn't, are they going to transfer the bugs between them? So I think that part they're still working out, but it will be able to, I think the settings, they were able to split them off. So hopefully it won't come to that. If anybody has kind of seen, the Defense Production Act has been enacted. So GE, GM, a lot of these companies have basically turned their production into creating ventilators. So Medtronic and a few other companies that make them have really answered the call. General Electric out in, I think in Washington State, where where they're making jet engines, all the employees basically went on protest and said we need to be making ventilators. So as of last week, they're making them. So another question from Astrid. Tylenol safe to take. There's been no issue with Tylenol. I think the one question that people had was about ibuprofen. So far, they're both safe to take. They work totally differently. What I usually recommend for patients is take Tylenol first. The maximum amount of Tylenol anybody can take within a 24-hour period is 4 grams. That goes down based on your age. So once you start to get upward in age, about 65, I think it gets down to 3 grams. You can only take, I think, 1 gram within every 6 hours. So if you take it and it's not coming down, the next thing you would probably want to do is go to ibuprofen. So Tylenol is safe to take. If your fever doesn't come down, the next step would be to take ibuprofen. If it still doesn't come down, you're not at a next level, ready for the next dose of either, cold bath. So that's like an emergency thing, and I think pediatricians recommend that, a really, really cold bath with ice pack. And that's what they would do for you in a hospital too. Donna, just saw you today. How are you doing, dear? Furanol. So that was something that I was just mentioning. My mom took Furanol. Furanol is a mixture of a couple different medications. Furanol can be taken, it's basically acetaminophen, caffeine, and a barbiturate. Caffeine is actually very good for headaches. The barbiturate is not necessarily good for it. But if it's something, I think we can definitely talk about it. One of the things that I prefer to do for headaches long term is ketamine. So I mentioned that if you tuned in before, ketamine is a really powerful medication for facial pain. It's something that works better than having to take Furanol every single day. So for those of you out there that are having chronic facial pain and migraines, ketamine is very effective, and again, it's covered by insurance. The only thing the person covers is basically the cost of ketamine, which is about $10, $15. So that's something I would probably tell you to lean on before I would start taking Furanol again. And Ben, thank you so much for the comment. That was really nice of you. I appreciate it. And hopefully I was able to, answer anybody's questions that are out there and kind of really, help people out. So if I'm going to sign off, if anybody has any other questions, feel free to email me. I'm going to put our office email here at the bottom. That goes to our general one, and then if you need to send anything to me, this is mine at Ainsworth Institute at aimpain.com. And then just get one other question here. Opioids, we don't know exactly how they do it. There's a couple different articles out there, but if you basically look up opioids and immune system, there's a bunch of different articles, some as recent as 2018, some going back to 1998. So we don't know how it is that they decrease it. Maybe it basically makes you more more nascent, more sedentary, but it does. So for those of you that are already taking opioids, don't take more. Okay, that's basically where it is. Your body gets used to them over time, and it's kind of like the law of equilibrium. Your body comes back up. So for those of you that are concerned about taking them, that like, oh my God, I'm on opioids, is it going to decrease my immune system? It is. But if you've been on a steady dose for a while and you're not increasing it, you should be fine. So the moral of the story is really don't take any more. And then the other question you had, Ryan, so what if one patient's lungs are stiffer than the others? Will the oxygen be able to... So is this, if you're talking about 2 patients, again, they're able to split off the pressure, so will the additional oxygen create a problem with the overall pressure and damage the lung further? Not really. So if a person's lungs are stiffer, I don't want to make myself look stupid here, but I haven't done intensive care in 10 years. But ventilators, when used in short periods of time, which is what people are using these for, it's not going to cause lung damage. What it's trying to do is to get people to get through this. It's trying to help them get through to the period where they can take a normal breath again. The settings are there to just get them enough oxygen. So when a person has pneumonia, they have water, the water's filling the lungs, and they have what's called a consolidation. So they don't have as much surface area to exchange as much oxygen. All it's doing is it's making sure that the breath that they take, that they get more oxygen per breath so that they can get enough oxygen in their blood so they don't get brain damage. One of my best friends in the world, Miguel, for Roboxin for back pain. I'm not a big fan of muscle relaxers. I think in general, they tend to cause more problems than good. The only muscle relaxer I've ever prescribed that I stand by is Xanaflex, or it's also known as tizanidine. It's an alpha-2 adrenergic blocker, so it actually does work in the central nervous system. It's an old medication that we used to use for children with cerebral palsy. If you take it at low doses at like 2 milligrams, like once a day, it helps people sleep. It can actually help, really help back pain. It's not addictive. And people can take it for very long periods of time. So I have a lot of patients that are taking it. They can tell you that it doesn't work for everybody, but for the patients that have been taking it, that they seem to work very, very well on it. So If anybody is having spasms or if they want to try a muscle relaxer, I would tell your doctor to try tizanidine, 2 milligrams once a day. So everyone who tuned in, thank you so much. I really appreciate you guys coming on, and anybody who is catching this after it's over, feel free to send me email, any one of the emails I put up there, and I'm happy to answer your questions. God bless you all, and stay safe, and hope to see any of you in person down the road. Take care. Bye-bye.